the intensive care unit, right? And emergency, right? Have you seen that in movies, if you have not gone to a hospital, they have the patient right there, laying in a bed, hooked up to all these cables and all these monitors over there, beep, beep, beep. Well, that's what we call continuous monitoring. Continuous, as the word implies, means somebody's hooked up to these machines and we are continuously seeing what's going on because they are in a critical condition. This is not someone who goes to the doctor's office and they're going to hook them up and keep it there. No, you go to the doctor's office, which is called an outpatient clinic services, because you go in and out. You don't stay there. When you are admitted, and if you are admitted, it's because you have a condition and it's serious, have to be treated directly at the hospital. They hook you up to all these machines. Well, one of these machines that they hook you to is an EKG machine. So if you see those little beeps, 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 it's because they are hooked up and they are checking their heart and the respiration, the oxygen levels, and sometimes the IV line that they're giving you medication, right? But the one that we are talking about here is the continuous monitoring. There are different types of monitorings in our hospital clinics or places where you're gonna be receiving care, medical care, right? So it says right here, bedside monitoring. Remember, bedside means that you are in a bed, you are admitted into a hospital in any of these specialties, but particularly when it has to do with the heart, because whenever you have a medical condition, what is the first thing that is going to fail? Your respiratory system. And if your respiratory is going to fail, your respiratory system is directly connected to your heart. So we need to know whether oxygen is going or not. And what carries oxygen? Blood. And who pumps the blood? The heart. So we need to know that your heart is functioning normally. So for that reason, you're going to be connected to these machines. This is what is called continuous monitoring. Is that understood? We're going to be checking you out all the time. There is a nurse coming in and out. There is monitors over there that someone from far away is checking that this person that is hooked up to the machine, everything is going right. So that's basically what it is. So that will be continuous. The bedside is the one. Now, in this case, for these patients, we're not going to attach 10 electrodes. We're going to do 5. So they're going to do it. And those electrodes that we use there are very, very strong electrodes. They are not the same little stickers that we use for the outpatient clinic. These are kind of round with a little nipple in the middle, and then it's clicked to these cables. Why? Because the patient is moving and we don't want them to detach. Because then if they detach, what's going to happen to the machine? This is going to sound an alarm. And somebody is going to go there thinking that the patient is dying or something else is going on, right? So this is continuous. So for me and for you, what I want you to understand is that when they ask you in an exam, when they can ask you a question, okay, when the patient is connected to a machine that is continuously running, what is called? Continuous monitoring or bedside monitoring. That's it. It's simple. But sometimes you don't think that is that simple, right? That's what they ask you. Continuous meaning that is connected continuously. And for the time being, for the time that you're being hospitalized, you have to be connected to those devices, machines. Telemetry. Nowadays, it's very commonly, and you hear about telemetry or telemedicine, because or telehealth, because it's very common. Tele means that is through the phone line that we are monitoring you. So let's say that we have someone far away where there are no like high-tech services, like underserved places, right? If you go to a small town where they don't have a big hospital, but they have a small kind of clinic or urgent care, well, by the time that the patient is brought to the city, to a huge hospital, probably the patient is going to die, right? So before that happens, we take you to these places. They have some monitors over there, but they don't have specialized people who's going to be monitoring this patient. They don't have a cardiologist. They don't have this. They don't have that. A neurologist. So therefore, the doctor in charge of that clinic, that is a regular general doctor, he is going to hook these patients up, or the nurse, but someone else from a big hospital from here is going to be monitoring the patient. Is that understood? That's what's called telemetry. So the key word for telemetry is remote monitoring. That is the key. Something that is remote. The patient is being monitored remotely. What type of services is that? Telemetry. That's basically what I want you to know. Just terms and definitions. Is that understood? Anything else? They're not going to ask you how many electrodes are going to be placed in these cases, because it varies, depends of the machine that you're using. Some of them uses 3 electrodes, some of them uses 5, some of them use 7. So that would be a trick question, right? That they put 5, 3, 7. Well, I don't know what machine you're using. So it wouldn't be a fair question. So they just ask you is if the patient is hospitalized and they have these patients monitoring all the time, what is called continuous or bedside monitoring. And if you remotely, as soon as you see the word remotely, telemetry. That is it. Any questions? Here we have samples. See, these are the monitors, and you see here the EKG, right? Here it is what? Here it is what? So we have here blood pressure, pulse, we have the oxygen levels, and the pulse, or the respirations. So usually we're going to see all of these vital signs. Because if we have you connected to a machine, we need to know what your vital signs are. Whether your oxygen levels are normal. Remember, oxygen levels, they have to be between 97 and 100. If it is less than 97, it's 96, patient can die. It's having problems breathing. So we have to be checking all the time. And monitoring the EKG all the time. These machines have an alarm. Whenever something goes wrong with the patient or the patient disconnects something, an alarm sounds off and someone comes over immediately because it's very loud. So somebody says, oh, something is happening, and then they go to that particular room and check the patient. That's basically what it is. So most of this happens at the ICU, remember, or emergency. In emergency situation, the patient doesn't stay there for too long. Remember, emergencies are for people whose life is at stake. That's an emergency. Of course, we use the emergency for other reasons, right? We forgot to go to the doctor and ask for our medication refill, we'll go to the emergency. That's not an emergency. An emergency is my life is at stake, meaning I'm bleeding profusely. I'm having a heart attack. I cannot breathe. I have a stroke. I have something really serious that can compromise my life. That's an emergency. So then we take care of you and then kind of stabilize you, because that's what emergency is for. We're going to stabilize, meaning we are going to put you in a level that can be transferred to the ICU or any of these particular specialties within the hospital when you're going to be receiving special attention from one of these special medical doctors, specialties, right? So we're going to direct you that. So usually at the emergency, you don't spend much time. Maybe 24 hours, 48 hours when we get all these under control, all these tests that we run, and then we send you to the floor. That's what we usually say. We send you to this particular department, this particular specialty, and somebody takes care of you. Now it says right here, the most commonly used leads for continuous monitoring are just this part. Lead number 2, because remember, every single time that we talk about the rhythm strip is number 2. Of course, we're gonna look at anything else, but for the purpose of your exam, that's the only thing that I'm being kind of, focusing on is what you're gonna have in your exam. Because anything else, that is the doctors, the nurses, someone in a higher level that have to deal with this, right? So for you, it's just lead number 2 is the lead that we use most commonly to check what's going on with the patient's heart conduction. Is that understood? Well, here are some of the places where we're going to place the electrodes. It is totally different. See, here we have 3. Here we have 3. Some of them have 5. Some of them have 6. Depends on the machine that we use it. Because not every single electrocardiogram that we use in the office, in the hospitals, are kind of standardized the same way. No, all depends on the brand, depends on the manufacturer. So then we usually follow the manufacturer company to place the electrodes. Every single EKG machine has a little label right there, has a little drawing, a little picture of where you should be placing these electrodes. Is that understood? And sometimes they are color coded, so you just place them exactly where the colors are guiding you, are directing you to place it. Anything else, do not worry about this. They don't ask about this. Says right there, normal QRS deflections. Now, one of the things that I want you to understand is this. ABRs. ABRs, usually in certain leads, you're going to see them upside down. Instead of seeing the P positive, the QRS positive, the T wave positive, you see them upside down. That is normal ABR. Is that understood? As soon as you see ABR, this lead, and if you see them upside down, because remember I told you that in a normal EKG, P wave is positive, QR is positive, and the T is positive. Here you will see them, all of them negative. But it's okay because it's ABR. That's the way that the picture of the electrical impulses are taken. It's like you're taking the picture like this, then it looks upside down. But that's how it is. So just in case, usually happens, they ask you a question in your exam, and they said, which of the following leads it will show the P wave, the R wave, and the T wave negative? ABR. Is that understood? Because those are kind of exceptions to the rule. There are other leads there, but I don't want to compromise you with that because it's better to know one thing that you know for sure that is going to be on your exam versus telling you everything else from the EKG, okay? So which lead on an EKG will show negative P wave, negative R wave, negative T wave? ABR. That's it. The other ones, mostly, is going to be normal positive, above the baseline. What is another name for baseline?
Isoelectric.
Exactly, isoelectric. When you see the word iso, anybody knows what iso means? You know what is electric, right? Of course.
Isn't it like separate? No?
Kind of close. See? What is this line?
Steady. Straight.
Straight. Iso means in one plane. In one direction. In one plane. It's not like goes up, down, up, down. No. This is iso. Flat. Let's put it like that. Flat.
Flat.
In a horizontal plane. That's iso. And then electric. electricity. So the electricity is going in one plane, straight. Because remember, we measured electricity on the horizontal lines. That's how we know whether it's positive because up or whether it's negative because it goes down. So isoelectric means flat in one plane. So it goes straight up, flat. Got it? Okay, so here we see in the pictures, right? Because we know that, so right here, P, positive, R, positive, Q, supposed to be negative, but it's supposed to be here, but it doesn't show because the Q is not seen in every single EKG, okay? So then we have the S. Remember, the S comes from here all the way here to here. So that will be negative. This T is positive. So we're going to see all these in these leads. You see over there? Lead number 1, lead number 2, number 3, ABL, and ABF. What is the ABR? Well, it's not because it's the opposite. Correct. It's upside down. It's the opposite of this. So if I know only one ABR that is upside down, why should I learn all that? I know that I remove that because it's an exception, right? So the only thing that I need to know is that ABR, it is negative. The waves are negative. So I know everything else is going to be positive. Here it is. This is ABR. Look over there. Just ABR. Doesn't have anything else right there. So all the waves are negative. The P, QR, and the T. See, when you see the pictures, then you have like a better idea, right? Versus just mention the definitions.
All right. So when it's so when it's up, it's positive. When it's down, it's negative, right? So, but is the reading the same thing or no?
Like, what do you mean by reading the same thing?
Like.
Okay, what you're trying to tell me is that even though if this is negative, this is positive, this is negative, it shows that the patient's heart is normal?
Yeah.
Yes, because in these leads, the picture is upside down.
Okay.
It's just the way that the electrical impulses are taken. It's the location. It's not that they actually like that, but on the printout, it's going to show like that. So let's say that this
actually supposed to flip it around.
exactly. Let's say that you're looking at the different. You have cameras. Think about you having all these bunch of cameras looking at the heart. This is the heart, and you have this camera looking right there, looking at there, but it's a camera that is looking like this. So then this part is gonna be looking upside down. This one from the front is gonna show normal, this one normal, this one normal, but it's gonna be one camera that is gonna make you look like you are upside down. Okay. Now, if you see an EKG and ABR is the other way around, now we are worried. Now we are worried because ABR is supposed to be showing negative. So then something else is wrong. So in an EKG, it has to be like that. It's not like that, then we have a problem. Then the patient have a problem.
So EKG always supposed to be read the opposite way?
No. This lead,
I'm confused.
we're talking about,
right?
the EKG has 12 leads. Lead number 1, lead number 2, lead number 3. All of these leads has to be this way. When you see it on an EKG, they have to be like this, always. Now we have the augmented ABL, ABR, ABF. Only ABR is going to be showing like this. Next one, upside down. Every other lead on an EKG has to be showing positive because this is normal. It's okay because the camera that is taking this part of the heart, it makes the picture looks upside down. And if it doesn't look upside down, then something is wrong with the patient. So that's basically what it is. Let's say then they taking pictures from you, right? But they take a picture from the bottom. You are stepping in the glass. I'm not gonna see your head. I'm gonna see your feet first.
So it's gonna
But if
come
I
out
take a
like-
picture from the bottom and I see your head, something is wrong with the camera. Something is wrong with you. Or you were your head were down.
Okay.
But this is just the location, how these electrical impulses are taken and sent into the machine.
Okay.
So this is how we have to see ABR all the time in an EKG.
Okay.
Now, if I see it normal like the other leads, then this patient has a problem.
Okay.
It's just the position, remember,
Mhm.
the position in which these electrical impulses are taken. Oh, that's it. All right. So, I made a mistake closing the other one. Because as soon as I open the other one, I have to enter all the information. Okay, how can I bypass this? Alexa. She's not gonna tell me, right? We're performing the EKG or ECG. Now we're gonna see how we're gonna place all these leads, the way that I was showing you over there. But not only that, all the steps that we have to follow to get to that point and get the printout, right? From the moment that the patient steps in, what is it that we do? How we place the paper? How do we know that the paper in that machine, it is correctly placed? How do we know that the paper on that machine is over? How do we go about dealing with the patient? Instructing the patient what to remove. Because remember, we are going to expose the patient. Most of the time, we're going to ask them to remove clothes from the waist up. So when the patient is going to do an EKG, we have to give all these instructions. Can you imagine, like some of the medical assistants, some of the nurses, even some of the doctors, they probably were thinking that the patient went to the school to learn how to do an EKG, right? They hand them a gown, There's gowns, you have to give them a gown to protect them, their privacy. So they said, oh, take this gown, go change over there. Seriously? What is it that the patient is gonna do? He's gonna remove everything.
Mm-hmm.
You don't need to do that. That's violation of the patient's privacy. So what you have to do is tell the patient exactly what you need the patient to remove. What should go disrupt yourself, seriously. Doesn't work that way. If it is a male, you're gonna tell them, hi, Mr. Mrs. Smith. The doctor ordered an electrocardiogram. As soon as you said electrocardiogram, if this person is the first time that is having that, they're gonna say, what is that? And they're gonna become nervous. Oh, the doctor wants to check how your heart is functioning, okay? Don't use these big terms because patients are gonna be apprehensive, thinking that they probably are dying. I can order an EKG, not because you're complaining about chest pain. No, I'm gonna do just a regular kind of physical exam. I need to know the basics, how you doing, you know what I mean? We usually order those for adults, not necessarily because you're complaining about chest pain. No, it can be part of the physical exam. Now, you have to explain then in very simple terms. Then the next step is gonna say, okay, what I want you to do is, you're gonna take this gown with you. I want you to remove your clothes from waist up. If it is a male. If it is a female, you're gonna do the same. You're gonna remove your blouse, your dress, you're gonna remove your bra. They have to remove your bra. Because we're gonna put the electrodes around here, and if they have a bra, how are you gonna put it?
Mm-hmm.
Now, think about those bras. Sometimes they have metal. They have some stuff right there. And then that is going to interfere with the current of your heart, the electrical impulses of the heart, so you're gonna have a distorted electrocardiogram. So all those things you need to pay attention. Now, for the males, you're gonna ask them whether they're gonna remove the shoes or not. That is not a big deal. But it is okay because you're gonna be going on top of the table, right? You don't wanna be with shoes, but you can leave your socks on. Now, if you think that that's gonna sting, wear a mask. That's what I do all the time. So, yeah, you protect yourself. You don't wanna be, smelling some stinky food over there. So, yeah, it happens. Listen, you're gonna have people over there that is gonna sting, not just the feet, everything else.
You're gonna have bumps from the street.
Right.
Yeah.
I'm telling you. So, never know who you're gonna counter. That's what you need to know where you're gonna be working. So, anyways.
And you can't be like, oh, you stink.
No, you don't say those things. You just breathe and hold it until the patient leaves. Oh, I just wear a mask. I'm telling you, I wear a mask.
Somebody told me they put 2 masks.
They what?
They put 2 masks. They double the masks.
Well, about that, I don't know, but yeah, because one is gonna allow 50% of the others coming through, right? Mm-hmm. I wear a respirator. Something that has now, just kidding. Just a mask. Don't exaggerate. So, we gotta get used to all these, because you don't know who's coming to you. So, be prepared. Next, you're gonna tell the patient if it is a female, and if they're wearing pants, some of the females like to wear these pantyhose, right? They have to remove them. Because when you're gonna place the electrodes on the patient's legs, how are you gonna place it on top of the pantyhose? That's not gonna do any good. So do it. Ask them, are you wearing pantyhose? Listen, most of you females that are gonna be working as a medical assistant, get familiar. But if it is a male, it doesn't matter. I tell anyone what I have to tell. Are you wearing this? Are you wearing that? This? Be real. Because that's how it is. It's just the way that you're going to say it. Hi, man. Are you wearing pantyhose? If you're wearing pantyhose, please, you're going to have to remove it, okay? And tell them, you're going to place your stop right here. Everything that is metals, all these ornaments that they put look like a Christmas tree. Because when they go to the doctor, some of the females, especially the elderly, they think that they go to church or they go to some places, this is their day off, and they put all these ornaments on top. No. Rings, anything that is metals, stuff like that, metals that carries a belt, that has a metal there, keys, cellular phones, nothing should be on them. So you're gonna tell them, please place all your belongings right here, so they know that their stuff is there. It's not understood? Because otherwise these metals, these keys, these coins, this wallet, this belt is gonna interfere. We're gonna see how an EKG that is done when there is interference of anything that we're gonna discuss later on, you're gonna see it in an EKG. And if you're not familiar, the doctor is. And as soon as you bring this to the doctor is gonna tell you, go repeat the electrocardiogram. And if you continue doing the same without moving or doing the right thing, it's gonna come out the same way. And the doctor is gonna say, tomorrow's Friday, right? So tomorrow's your last day. Thank you very much. And then you're gonna say, oh, why? I'm being here all the time. We don't care about that. Anyways, you're just gonna do the right job. That's basically what it is. We don't want to waste time. Because for the doctors, it's a waste of time checking at the electric. As soon as we see it, I know it. I'm telling you, you're going to get familiar with these electrocardiograms. When you see something weird right there, you don't know what it is, but you know that it's not right. Not because you didn't do right, but the patient has a problem. And if you didn't do it right, you're going to know it because I'm going to explain you and I'm going to show you pictures of how something that was done wrong because of you, your steps, you failed to do this or that, how it's gonna look, this electrocardiogram, then you're gonna notice and then you're gonna say, oh no, I have to correct this before I bring it to the doctor. So you're not gonna print anything out until you see that everything is working normally, so that you can see all of these waves. Other than that, it's gonna be obscure, so we're not gonna be able to read it, interpret it. Okay. Next step, remember, we're gonna clean. After you tell the patient to remove the clothes and the metals, whatever they have on them, then we're gonna tell them then to put the gown. Now, be careful how you tell them to put the gown, because the opening needs to be to the front, because this is the place that we're gonna be. People tell, oh, put this gown on, and guess what? They put it to the back, the opening to the back. And then when you go there, you get upset. I've seen these medical assistants and the nurses, even the doctors. Why is the opening to the back? You're supposed to turn that. That causes a little inconvenience, because the patient, if it is a female, they like this, covering, or they tie it up so 100 times on the back. No, just tie it up nicely, but I'm gonna need the front, because I'm gonna be able to open it up, expose one space at a time, and clean that area with alcohol. That's what we're gonna do. We're gonna clean with alcohol the spaces. I'm gonna show you exactly how you're gonna do it. The spaces where you're gonna put the electrodes. Because remember, what he said, oh, but I took a shower, you don't need to clean. Oh, no, that's not the case. We like to put creams, we like to put stuff right there, powders. We sweat. Our own natural oily glands secretes oily glands, and then these electrodes are not gonna stick. They're not gonna adhere to the skin. That's the problem, because we're gonna see that it's not connected, that there is no electrical impulses moving from the heart through the skin, through the electrodes, through the cables, to the machine. And we're gonna see it. And that means you didn't do the job the way it's supposed to. So being fast does not imply eliminating steps, doing shortcuts. Shortcuts are not good in medicine, because one shortcut can cause my patient to be in deep trouble. So always try to do the things the best that you can. Believe me, consciously. Think about that this patient that is there is you, and that somebody's treating you right. So other than that, well, things are not gonna go well for you, because eventually the doctor is gonna get rid of you. It doesn't matter if you're there on time. It doesn't matter if you are look cute. That doesn't matter, because this is a lawsuit that is calling for, right? Not doing the right thing. So for that reason, it's very important that we do this. Then we're gonna ask the patient to lay down facing up. Remember, the patient is gonna be facing up. So this is the place where the patient is gonna be facing up, because we're gonna use their chest, and the head of the table needs to be elevated at least 15 to 20 to 30 degrees. So it's not that they're gonna be completely flat like here. No, you're gonna raise the headboard a little bit, or the part where you put the head a little bit. Most of these beds, they can be adjusted to that, right? Why do we do that? Because when someone, can you sleep completely flat?
No.
It's very uncomfortable. When you lay it completely flat, you're not gonna be able to breathe normally. And what is it that an EKG is doing? Checking all that. If you cannot breathe normally, you're gonna be moving, you're gonna be kind of starving for air, and that's gonna be shown on an EKG, all these deflections and necessary deflections. That is gonna be shown on an EKG. So you place them in such a way that they're gonna be comfortable, and they're not gonna be moving, they're gonna be breathing normally. So that's how it's done. You provide them blanket. Always. See this place right now? See yourselves?
That's how the hospital.
Elderly. Females. Females by nature, they are anemic. You guys can look pretty cute, pretty young, but it's not called for me, but it's called for you. So in these areas, in these hospitals, in these clinics, we always gonna have air conditioning. We always gonna have the temperature a little below that the normal temperature outside. Is that understood? What is the reason? Anybody knows? Why do we keep this? Correct. We're gonna keep those germs from not spreading, not moving fast enough. They're gonna be there, but we're gonna retain them in this area. If somebody's coughing right here, if somebody has an infection, these microorganisms are not gonna move there with it because they are kind of frozen. And we're gonna keep it here. So don't bring it anywhere else. So that's the reason why. And now, if I'm cold, and on top of that, you ask me to remove my clothes, lay me down on top of that table, what do you think my body's gonna be? Shivering. I'm gonna be moving. I'm gonna be like when you are cold, right? And can you imagine? You don't have clothes on you. Most of the clothes are removed. And then you ask them to wait there. And you take your time to do things. So the body starts shivering, kind of shaking. When you're gonna do the electrocardiogram, that's gonna show on an electrocardiogram. So you're gonna be seeing other waves, other deflections that shouldn't be there. So that is going to jeopardize the reading of the actual waves that I'm looking for. You're gonna be more P's, more QRS's, where not supposed to be because the patient is moving. So I'm gonna show you how you're gonna prevent that by following all the steps correctly. So you don't have to repeat this process. So the patient is comfortable. Who wants to go to the medical doctor and put on top of the table for 15, 20, 30 minutes, waiting for you to decide when you're gonna do the electrocardiogram? When we go to the doctor's office, we wanna be in and out. How many of you have gone to the doctor and they put you to wait there 30 minutes? Well, you're lucky if you wait 30 minutes. An hour, 2 hours, 3 hours.
Oh no, because
I
after
start
30,
flipping.
45 minutes, I'm out.
And then you bring them to the table and you ask them to remove their clothes, and this is cold. So their body is going to, and they're going to be upset already. And if they are upset, it's going to show on an EKG. It's not going to show there, I'm upset. No. It's going to show that they are frustrated, they start moving, they start moving. Or they actually go there and they say, no, I don't want to do it. I don't want to do the EKG. Actually, I got to go. So that's what we have to be kind of very nice with people. Try to relax them a little bit so they feel comfortable when they come to you. Because sometimes it's not your fault that they're not being seen. You're just the medical assistant. But because you're the first person that they get in contact with you, they vomit all this hatred, all this frustration on you. Don't take it personal. Don't talk to me like that. You're not my mom, you're not my dad. I'm not the cause of all your problem. That's not how, and that's how we respond, right? No. We have to try to put ourselves on the person's shoes to see why they are reacting like that. We have to have patience. We have to understand, be empathetic. Empathy. We lack empathy a lot. So we're always in a hurry. We're always in a rush. Always doing things like that. But when someone wanted to do it to us, we don't like it. But we do to them. No. In a hospital, listen, if I have to spend a little more time than usual, I'd rather do it, but do it right. So that's basically what we do. And then you prepare the whole scenario for your patient. Remember, we always prepare. These areas, when we do electrocardiograms, has to be areas that are kind of quiet. There's not much noise. Why? Because the patient is gonna be pending. Oh, somebody's screaming over there, and it's gonna be moving. So the faster that you do it, the better. Because the less time that the patient is laying down on that table, the best. So you don't have to, spend too much time. Is it raining again?
No, that's the AC.
Oh, okay. So that's basically what you have to. So we're gonna go through all that because that is exactly. So I gave you kind of a summary what we're gonna cover. Of course, there are more, but these are basically what is really important for us. Then we're gonna have some special situations. Dealing with child, little problem right there because they don't stay still. They don't wanna do the things that we ordered them to do. But then the children always go with who?
Your mom.
With the mom, with the dad, with the custodian, with whoever else, an adult person. Well, we in charge them to do it, to help us out. You know what I mean? So, and we have to be very nice with the person that brings the child too. Because if you are rude with this person, and that's not good. We're gonna also learn how to do an EKG on a pregnant female. Can we do an electrocardiogram on a pregnant female?
No, isn't it that the sharp? Right?
I think-
Can we
yeah,
do
I
an
think the strap is
electrocardiogram
for the
on a
Yeah.
pregnant female?
Yeah. I don't know.
And we're gonna respond that, no
I don't
worries.
know.
Can we do an electrocardiogram on a pregnant female?
No.
Yes or no? Yes. This is a non-invasive test. Doesn't have radiation. If it is X-rays, that's a different issue.
Okay.
Then we have to use a shield to cover the fetus or the abdomen. Particularly depends on the pregnancy, time that she is in, because at the beginning it's very dangerous because the baby is just forming and X-rays can damage them, their structures. But electrocardiogram, no contraindications to do.
So like she was saying, because when I was pregnant, they put the thing on to check the baby heartbeat. So
But they told me it was to check the stress level too.
yeah, like they put a strap around you.
To do an EKG?
I don't know. It looked
No,
like
no,
it
no,
was
no,
an EKG.
no. That's a sonogram.
No,
No,
not
it's like a
sonogram. You don't
strap.
see the
It's like
baby.
a belt, and
And
it
it be
has
on the
like a
machine. And it be on the machine.
Oh no, yeah, but that's not for that. That's checking the baby's heartbeats and all stuff. Or checking the baby's heart,
So that's basically a
electrocardiogram.
baby's EKG?
Right.
Oh.
That's a different issue. No. We're talking about here. No, a pregnant female, we do it. You just have to check the places where we're gonna move little things here and there. Okay, it's the same for a child. What is it? Can we do in a child? Of course, anybody can have an EKG. It's not invasive. It doesn't cost. There is no contraindications for it. Anybody can receive an EKG. So from the a patient who has a pacemaker can have.
I was gonna ask you that.
Can I see? I always have the answers for that. A patient who has a pacemaker, can we do an electrocardiogram? Of course. What is the pacemaker? My pacemaker is not working, so they put me an artificial one. I need to know if that artificial one is working or not.
Yeah.
So we can also do. There is no contraindications for an EKG.
Okay.
See?
So only for X-rays.
Exactly. X-rays,
I thought
MRIs.
it was like the same.
CAT scans, certain tests. The sonograms are the safest one for the females. Now, if it is needed, now we do an X-ray, but not to the belly. We cover it. We put a shield right there, so we cover you, like an apron, like has lead, so doesn't allow the radiation to pass
Yeah, I
through.
had to get an X-ray one time.
Says right there, preparation for the procedure. Select the room away from electrical equipment and X-rays. So what we're trying to tell you is that you have to be your machine has to be a little away from other electronics because of what happened? What happens if I have another electronic? It's gonna interfere.
Yeah.
Now, if I'm gonna tell you this, you're gonna say, yeah, I seen it. When you go to the doctor, you see no phones, no these laptops, no electronics. It's not because you are making too much noise when you're talking on the phone or using electronics. No, it's because they make interference with the electronics that we have these people who carry to it. Remember, we have this continuous monitoring, right? And if I have a phone, that can interfere with that machine, and that machine can stop working. So we actually kind of killing the patient softly without not knowing, right? So be careful. That's the reason why. It's not just because we're going to keep kind of control, because can you imagine all these people talking and doing things right there when we don't want them to be here. But here is because of interference. And if there is interference, because you're going to be carrying your phone, you have it right there in your lab coat, on your pockets, don't have it. Because I'm going to show you how an EKG is going to look like, not because the patient has keys, not because the patient has carry electronics, it's because of you. You have your phone right there and you're doing the electrocardiogram, it's going to show right there. And then I'm going to tell you, you were with your cellular phone when you were doing this EKG. Me? No, I didn't say that you were using it. No, you were carrying it with you. If I ask my patient to remove all these electronics, but you carrying yours, what is the purpose? Makes no sense, right? So, see, when I explain you things, I explain you all this because I've been there. I've seen it, I've done it. And we put the electronics right next to the machine, and then we ask you to do an electrocardiogram on someone, and we see all the changes. We remove the electronics, we repeat it again, and we see that these problems are, fixed. So it is true. This make you waste time. And of course, the doctor is not going to be able to read it, and it's going to ask you to repeat the procedure. So that's basically. Turn off non-essential electrical equipment. So, in other words, try to have your EKG machine away from other electrical equipment. But if it happens that you are in a room where there are bunch of other electronics, because usually they are. So then, this is what you do. You put it a little away from, or you put them off. If they need, if you can do it. If it is a machine that has to be on all the time, it's like your refrigerator, right? You can't unplug your refrigerator because you're going to do something. Well, it has to be on all the time. So then, place the equipment away from them. See these beds that have these metal rails? The patient, when they lay down over there, they should not be holding those rails. They should not be touching with the elbow those rails, because that interferes with the reading, with the machine. Because the electrical impulses are going to those metals, they're going to deviate from it. And then we're going to see the changes on the printout. Believe it or not, that's how we know. So we're going to go through all that. Place EKG machines away from electrical cords. See, it is recommended that if you have an electrical cord, because the outlet when you're going to place your EKG is close to other equipment, make sure that your EKG is the only electronic that is attached to this extension cord. You cannot have two things attached to the same extension cord. Like in my home, like have 10 equipment. You see, sometimes you have like this electrical sorter, then you apply, you connect lots of stuff. Well, sometimes I have like 6 computers attached to it. Well, with electrocardiogram, because this is the health of the patient and there is going to be interference, so you don't do it, right? So try to not. Try to avoid these extensions as much as possible. But if you're going to use it, it has to be for single use. It can have 20 spaces, but you only plug your EKG machine. That's what I'm trying to tell you. Any questions about that? Verification. The first thing that you're going to receive before you encounter your patient is a requisition form. Just similar to the one that I gave you for the blood, right? So the doctor is going to give you a paper when it has all the patient's information, the patient's insurance, or the form of payments, the address, the telephone number, contact information, all the patient's information is going to be there. Then, or the doctor just give you the patient's medical record, or just the little encounter form, which is the information that the patient has there for what we did today. So that's basically what it is. But the patient information is there. So you're gonna make sure that you have the right patient. Always. Patient's name identification number. You need 2 points. Exam questions for the exam. In order for you to identify your patients, you need 2 points identification. That's how they call it. 2 points identification. What are those 2 points identification? Full name. Full name means name and last name plus date of birth. Because this patient can have the same name. Well, the last name will be the difference. These two patients can have the first name and the last name the same. What makes the difference?
The date of birth.
Birth. Right. That would be kind of odd to find two people with the same name, last name, and the same day of birth. Well, it's just not happening. When I was working at the hospital, we have, I will never forget because a lot of things happen. I have 7 patients called Maria Rodriguez. See, Maria is a very common name, right? And Rodriguez is a very, very common last name. So I was seeing my patient came in, then I asked, at that time we were using the paper-based medical records, right? The files were in paper. So nowadays we use computers. So at that time I asked one of the assistants, I said, can you please give me the chart for this patient? I said, I gave it to you. So I said, I'm sorry, I didn't see it. So they put it right there on top of the desk and look at the patient and says, okay, Mrs. Rodriguez, even though if I'm the doctor, I don't call that, okay, Maria. No, Mrs. Rodriguez. This is the respect that we have to give to our patients, right? Regardless of, titles, age, or anything like that, except for children. Children, a child, you're not gonna call Mr. something. By the way, what is a child? What is a child?
Under 18.
Correct. Anyone who is under 18 is a child. So I took my son, he was 17. My son is 6'3". He's a little taller than me, right? You didn't get it.
No, I got it.
Okay.
I got it.
So I took him to the doctor, right? And he says he's pediatrician. Because if you are under 18, you have to see a pediatrician. It doesn't matter how big you are. Or how big you think you are. And then I took him over there, and this person who registered my son for that day, he put him to see an internist, which is a doctor who sees adults. So I was like, because my son is big, right? I think I need kind of authorization. So when they're little, then they need authorization. So they saw him and says, look at him. So the girl went over there and said, yeah, I'm gonna take care of you. And she put it to the, well, it turns out that when he went over there, after half an hour, they have to wait. The doctor says, sorry, but you have to go see the pediatrician. And he was like, what do you mean? I made fun of myself because listen, my little thing. And, he told me, he said, Daddy, I was there waiting, call these people. I said, listen, what happened? He said, I was waiting over there to see the doctor, and they think that I'm a little kid. I said, you are? No, Daddy, no, you're tall, but your ears are small. You're 17. So what? You're 17. You're a pediatrician. You have to see the pediatrician. The pediatrician. And he says, no, I'm not a child. Yes, you're a child. No, I'm child for you because you're my daddy. Because I call him my baby, right? It doesn't matter. So, anyways, you need to know the difference of all these things when you start working. So after he waited for over 30 minutes, he went to the room to the doctor, and the doctor looked at his medical record and says, no, wait a minute. You're a child. You're a minor. You have to go, no, you can see me. No, I'm a man. No. You go over there to see PBA. Now you have to start all over again. So going back to this patient, Maria Rodriguez, I asked the medical assistant, I said, okay, when she stepped out, which we brought me the medical records, that was not the patient. How do I know? First of all, Maria Rodriguez that I have with me, it was pretty young. But this medical record, it was fat. So what it means, someone who is just starting their life, how is going to have a big medical record like this? Like a big Bible. So I look at it and said, by the way, what is your first name? She says Maria. And because I called Mrs. Rodriguez, and I said, I just want to make sure. And what's your day of birth? Said, Chima told me, says, it's not right there in my medical records. That's the problem. Because I don't see you being born like in the 40s. Oh, she's pleased. Oh, no, I knew it. So I called the medical assistant and I said, I just dialed the phone right there and I said, listen, come here. I need you to bring me the chart because you wrote me the wrong chart. Now, again, this is to tell you that you cannot just go and check one thing because you might have the wrong patient. Other things that you as a medical assistant do because you don't follow the policies, you just think that you know too much, is when you call the patient, you do the same. You usually don't use the last name. Maria, Jose, Michael, Peter, Paul, Mary.
They do it a lot. They do it a lot.
Yeah, they do that. And then there are two Michaels, there are two Marias, and one of them that was paying attention because the other was on the phone or doing something else or talking to the neighbor. And then they come here, and then you just take them over there. Okay, remove your clothes, do this. And it turns out that that's not the patient. Can you imagine all that? All the time that you're going to waste. And it turns out that that's not the patient. And you're going to give the results to the wrong patient. If that happens, that, oh no, it came normal, so nobody's going to bother. And you put all the information on this patient, that is not the patient. So think about that can cause lots of troubles. Losing your license, being sued, even put in jail. Oh, well, I don't know about that, but I wouldn't like to be there. I'm going to be in Brazil instead. So anyways, so be careful when you're checking all the information. Remember, identifying your patient correctly needs 2 points. Full name. Usually in medicine we call it full name because that includes first name, last name. Is that understood? Plus day of birth. 100% is going to be on your exam, your national certificate. Oh, that's for a fact. It's like I'm seeing the question right now. Okay, how many points of identification you need? What will be? 2. Because that's what you need to know. Others, they're going to ask you, there are 2 points of identification. Which ones are? And they have a little group, A, age, and day of birth. Oh, age and day of birth, isn't it the same? Pay attention, everything. Full name. First name and last name. Is that 2 points identification? No, that's the full name. So pay attention to that. Identification number. When you're going to get an identification number? There are 2 ways of getting an identification number. Remember, usually when we have a doctor, they assign us a medical record number. That's an identification number. That is if you are in an outpatient setting. Now, let's say that you are hospitalized. What is the identification number? That number that they put on your bracelet. Whether if you're an adult, it's going to be on your wrist. If it is a child, it's going to be by the ankles. So all these are identifications. So be careful what the question is asking you, whether the patient is an inpatient or an outpatient. So know the difference between those two, because within the exam, they always play with those roles. So you go say, oh yeah, I will ask the name and last name. No, that was wrong. What if the patient doesn't have identification and if it is hospitalized? They don't have the wristband. They don't have the ankle band. They shorten it off. They were kind of a little loco, and they remove it, and you don't know what it is. Or it is on the floor. You have to call the nurse in charge. You never do anything. Don't give medications. Don't do exams to someone who don't have identification.
And you always have to identify every time you go.
Correct.
Right?
Every single time. And make sure that the name that is on that wristband or whatever other label they have, it has to match whatever information you have there. Because other than that, you might be giving the treatment to the wrong person. And that is a huge mistake. Remember, that's a lawsuit right there. Location, date, time of the recording. So these are the information that you're going to enter in the machine. So sometimes you might enter lots of information. So I'm going to show you the basics that you have to enter, and depends where you're working at. If you're working with a regular doctor, you don't have to enter diagnosis, you don't have to enter medications, no. Now, if you work with a cardiologist, you have to do that, because this is the specialist. This patient was referred from the general doctor to this specialist. So now I need to know most of the things. Even makes not much sense, because if you come here complaining about something, I should be putting medications, because remember, medications can show that your blood pressure is not high because it's controlled, right? Not that you don't have blood pressure. So once again, but in a cardiology, you will put more information. The information that you got to put on those machines when you do an EKG on an outpatient is full name, day of birth, today's day, and the time that you were there, your initials. Sometimes they have the medical provider that ordered that, because that gotta go directly to that doctor. If this is my patient, you have to bring that EKG to me, not to the doctor over there. Is that understood? So you have to present this to the doctor that this patient is with. It's not like because you're a doctor, I'm a doctor, but this is your patient. Whatever you order to the patient, come to you, not to me. Is that understood? So sometimes you're going to encounter people who don't know. Oh, the doctor wasn't there. And then you say, oh, doctor, can you do this? Because the patient is here, I want to know the result. You cannot give me information from a patient that is not my patient. That's not my responsibility. Oh, but you're a doctor. Correct. So, oh, but you're a doctor. No. See? That's a person, that's a girl, but I cannot go kissing all of them, right? Just kiss the one that allowed me to, right? So that's basically what it is. So based on HIPAA, privacy, and confidentiality, you only address the things that are pertaining to you, not everybody else. So once again, pay attention to that. Patient's age. Yes, we need to know how old is the patient. Gender. I don't like the word sex. It sounds like sexual, right? Like sex, like doing something there. I don't like it. So usually it says gender. Male, female, other. So we have others. So make sure that you record it if it is written on the medical records. That's basically what it is. It's not that you're going to ask the patient, are you female? Are you transvestite? I don't know. Maybe you are binary. Remember, that is very serious. Because people don't, remember, it's how you say it. Not what you say, you know, how you say it. How you ask. So be careful with all those things. Don't make fun of things, because that is very serious in the workplace. Somebody has a kind of funny name or something, don't make fun, don't laugh, bite your tongue. Somebody has some physical problems, don't laugh at them. Because sometimes you feel like when they talk and they go, wah, 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 and then you say, oh my goodness. No, but just hold your horses, because that can give you trouble. I'm telling you, respect other people. That's what we have to do. Sometimes it's a little harsh, right? So step out the room, make excuses, go there, drink some water, drink some Bacardi, I don't know, but don't do anything wrong. See, cardiac medication sometimes depends where, but most of the time no. Weight and height is important because depends on the age of the patient. We know he might have this condition, right? Or might have already some chronic conditions that are related to whatever the patient complaint symptoms are. And weight and height also important because depends on the weight also can cause heart problems, obesity, for instance. So we always write, we're not gonna put that the patient is obese. We are just gonna write down how much their weight in pounds, what is the height, things like that.